Hi everyone, and thank you for taking the time to listen to my PowerPoint presentation on human papillomavirus, or HPV. I have to admit up front that this is my very first time creating a voiceover PowerPoint, so I'm asking you to please bear with me. I'm not quite the technology whiz that I wish I was. So I wanted to start first with a little bit of background information on HPV so that you all could understand the sort of scope of this problem, and then I'll move into the pathophysiology. All right. So HPV is one of the most common STDs in the United States. There are over 100 different types that are known, and of these 100 types, over 40 different types are known to affect the genital tract and be sexually transmitted. Genital HPV types can be classified as either low risk or high risk based on their level of association with cancer. Fortunately, a vast majority of HPV infections, whether caused by the low risk or the high risk types, are transient, asymptomatic, and have no real clinical consequences. So, like most of you know, transmission of genital HPV is primarily through sexual contact. And interestingly, in some cases, transmission can be from mother to newborn during childbirth. I actually didn't know this before doing the presentation, but this can lead to warts of the respiratory tract in children, and this infection is known as recurrent respiratory papillomatosis. A little bit of epidemiology here. There are about 14.1 million new cases of genital HPV that occur annually here in the United States. This results in approximately $1.7 billion in direct medical costs for treating the illness. And in all actuality, these numbers may be much higher, but the statistics are sort of limited because HPV isn't currently a reportable sexually transmitted infection in any state. Like chlamydia or gonorrhea is reportable, HPV is not. So in all likelihood, these numbers may be significantly higher. The Centers for Disease Control and Prevention estimates that almost every single sexually active man and woman will acquire genital HPV in some time in their life. I thought this was absolutely shocking. 79 million women between the ages of 14 and 59 years old are infected with HPV, and the highest prevalence of the virus is in those women ages 20 to 24. All right, now that we got that out of the way, time for some more sort of hardcore pathophysiology. So genital HPV is a double-stranded DNA virus that has a special affinity for the genital skin and mucosa. Initial infection occurs at the basal cellular layer of stratified squamous epithelial cells, and this initial infection triggers cellular changes in the epithelium that can range from really nothing at all to some hyperplasia to some minor dysplasia, maybe some more severe dysplasia, and in some rare cases, carcinoma. The incubation period for HPV infection really varies from person to person and depending on the type of the virus acquired, but the median duration of infection is about 8 months. And again, as I pointed out earlier, most infections are subclinical with no real significant consequences, and over 90% of all HPV infections are thought to clear within 2 years. So that's sort of a reassuring statistic, I think. Next, I'd like to take some time to focus on the differences between the low-risk HPV and the high-risk HPV. Low-risk HPV includes those types of the virus that are not associated with cancer. These are the types of HPV that we typically associate with genital warts and even some very minor cervical changes. Because the low-risk HPV is not associated with cancer, it's often termed non-oncogenic HPV. I was interested to read that only 2 types of low-risk HPV, types 6 and 11, are responsible for causing a majority of genital warts. So of those 40 types we talked about earlier, only 2 types are responsible for a vast majority of the cases of genital warts that we see as clinicians. The recurrent respiratory papillomatosis that I mentioned earlier, that type of HPV is also classified as low-risk HPV. High-risk HPV, on the other hand, is associated with cancer. So these are the types of HPV that we refer to sometimes as oncogenic HPV. Again, only 2 types, types 16 and 18, account for almost 70% of all cervical cancers. So it's sort of like this type 6 and 11 causing all the genital warts. Type 16 and 18 of high-risk HPV are responsible for almost all the cervical cancers that we know of here in the United States. High-risk HPV sometimes can just cause low-grade cervical cellular changes. It can cause high-grade cervical cellular changes, and in some cases it can cause cervical cancer. I think it's important to point out here that high-risk HPV, much like low-risk HPV, does not exclusively affect females. In fact, according to the CDC, high-risk HPV can cause all types of anogenital cancers, including penile and anal cancers in men. In addition, genital HPV has been linked to cases of oropharyngeal cancers in patients who commonly practice oral intercourse. I felt this was an important section for me to include because many people hold the misconception that all HPV causes cancer, or that same HPV infection that gave a person genital warts can lead to some horrendous cancer down the line. So now we sort of know the difference between low risk and high risk HPV. And the pictures on this slide, one is just of some examples of penile warts, and the other sort of shows a spectrum from normal cervical cells all the way up to cancerous cells. So it gives you some idea of the visual of the cellular changes that can take place as a result of HPV infection. Okay, so next let's move on. The differential diagnoses I've decided to include. Obviously, you can see I've decided to include 3: herpes simplex virus, cervicitis, and normal anatomic variants. So first of all, like low-risk HPV, infections with the herpes simplex virus can lead to skin growths at the infection site, and the two viruses also have in common the fact that they often are asymptomatic and can go undetected. Unlike HPV, though, symptomatic herpes infections often leads to these painful clusters of fluid-filled sort of blisters or vesicles, rather than the painless, more dry sort of genital warts that we commonly associate with HPV infection. Cervicitis, just a fancy word for inflammation of the cervix. This could be misinterpreted as high-grade cervical cellular changes caused by HPV by an untrained eye. So sometimes cervicitis actually is associated with cervical malignancy, but most of the time it ends up being caused by an infection with another STD like chlamydia, gonorrhea, or even herpes. Lastly, I wanted to include normal anatomic variants as a diagnosis. I thought this was important because sometimes genital warts can be confused with normal pre-existing anatomic variants such as a skin tag or a freckle or something like that. So how do we as future clinicians go about detecting HPV in the clinical setting? Unfortunately, there are still no laboratory tests that are approved to detect HPV in males. So there's no blood test we can order or urine sample we can get that would tell us whether or not a male patient has HPV. Genital warts are typically diagnosed just by visual inspection, although they can be removed surgically and sent to the lab for further pathology testing if a clinician deems that necessary and appropriate. For females, the Pap test or Pap smear is the first step in detecting the cellular changes that can be caused by HPV. The Pap test is recommended at varying intervals for all women ages 21 through 65. During a Pap smear, the clinician visually examines the cervix and the areas around it and collects a few cells to be sent off to the lab. The laboratory puts these cells on a slide and further inspects them under a microscope to make sure that all the cells are normal. If they're not, then we sort of go down the line with further testing. We'll get to that later. And then in addition, the cells from the Pap smear can also be directly tested for HPV with a DNA or mRNA test. And I found it kind of interesting. Sometimes the cells may appear normal on the slide, but end up testing positive for HPV, and vice versa. Sometimes the cells appear abnormal on the slide, but end up testing negative for HPV. So the next step in screening is called a colposcopy, and it is often recommended in patients with abnormal Pap results, particularly if it's their first abnormal Pap smear or if there are relatively significant changes observed from the Pap smear results. The colposcopy is a procedure performed with a low-powered microscope. We call this a colposcope, which allows the clinician to get a much closer look at the cervix and surrounding areas. During a colposcopy, acetic acid is often applied to the cervix, And the acetic acid makes these sort of previously inconspicuous cervical lesions become much more visible, and it actually turned the genital warts and dysplastic areas of tissue this white color, so it's easily observed by a clinician. Tissue biopsies can also be obtained during a colposcopy and then sent to lab for further analysis of the degree of cellular changes that are taking place. And then, depending on the severity of those cellular changes that are observed on biopsy, further treatment modalities can be recommended. So, modalities, well, for genital warts, the treatment regimen is pretty straightforward. Patients can choose to apply one of the medications listed on the screen, or there can be provider-administered treatments like cryotherapy or a surgical excision. And some patients may choose to just let the warts resolve spontaneously. If a patient decides to do nothing, the wart may resolve on their own. They may proliferate and become more severe, or they may just remain unchanged for some period of time. On the other side of things, cervical cellular changes are a bit more difficult and complicated to treat. So the treatment modality for cervical cellular changes is sort of determined based on the patient's age, their personal and family history, and then the severity of their cellular changes. I found that the American Society for Colposcopy and Cervical Pathology's website offered this really extensive algorithm to help kind of guide clinicians in the treatment of cervical cellular changes. And if any of you are curious about this topic, I totally recommend checking out their website for a more detailed description of these guidelines. Unfortunately, it's just the guidelines are way too extensive for me to include in this particular presentation. Essentially, the treatment for cervical cellular changes includes some combination of repeat screenings, either excision or ablation, and in some severe cases, cervical surgery or a total hysterectomy. All right. So in terms of HPV prevention and health promotion for patients who are currently living with an active HPV diagnosis, there are several important interventions that I wanted to discuss. First, regular cervical cellular screenings, or cervical cancer screenings, I apologize, for women is a really key step in virus detection and prevention. Because HPV is sexually transmitted, patients who have a known diagnosis may also benefit from testing for other STDs. It's not like a mutually exclusive thing. A patient with HPV could also be living with one or more other STDs, and so it's recommended that they receive a comprehensive STD screening. Next, there are 2 HPV vaccines available that can prevent against genital warts and the cancers caused by HPV. The Cervarix and the Gardasil vaccines both protect against most cases of cervical cancer, and then the Gardasil vaccine is unique in that it also protects against most types of HPV that cause genital warts. HPV vaccines are currently recommended for children ages 11 to 12, and either the Cervarix or the Gardasil is recommended for female patients, whereas only the Gardasil vaccine is recommended for males because it has that sort of added protection for the genital warts. It's good to know that even patients with an active HPV diagnosis can be vaccinated, and while the vaccine won't treat their current HPV infection, it can still provide protection against infection from other types of the virus in the future. So if anyone is curious about who should or who can be vaccinated for HPV, please check out the CDC's website for a more detailed vaccination schedule. Condoms can be used to lower but not completely eliminate the chance of transmitting HPV, but only if they're used consistently and correctly. So obviously genital warts can occur in places that aren't covered by a condom, so in those instances condoms probably wouldn't be useful, but they can help reduce the risk of transmission if used correctly. Patients with active genital warts should avoid sexual contact with new sexual partners until the warts have completely resolved, and they should inform their current partners about having the genital warts. Limiting the number of sexual partners can also help reduce the person's risk for transmitting or acquiring HPV, but again, this practice isn't perfect, and it only takes one sexual encounter with one person to transmit or acquire the virus. So in the end, abstinence or abstaining from sexual activity is the most reliable way and the most dependable way to prevent HPV infection um, that we know of. So thank you all so much for listening to my presentation. I ended up having a really good time putting it together, and I hope you enjoyed it too. Please offer any questions, comments, feedback below, and I will do my best to get right back to you in a timely manner. I'm looking forward to watching the rest of your presentations, and I hope everyone enjoys the rest of their week. Thanks so much.